This is another clinical case in which the child had a very large lesion that was all but impossible to isolate. The advantages here of glass ionomer are manyfold. My material must be moisture tolerant, but in addition, I want the advantage of fluoride relief. And thirdly, it's a large lesion on a permanent tooth, and if I can have a material that has the same coefficient of expansion as the tooth, then this child is going to feel more comfortable and there's less chance of marginal breakdown and leakage. This is post-operative photo, and she's had no post-operative discomfort and our margins are still intact in this case. This is a significant lesion on the distal of second primary molar, in which I've chosen to place a resin-modified glass ionomer and follow with a layer of flowable composite to seal the restoration and the tooth. I want the fluoride release of the glass ionomer to help to protect the mesial of the permanent first molar. I want the strength of the resin in the glass ionomer due to the size of the lesion, and I want to protect it occlusally from dissolution. This is preoperative photo of that same child. And this is preparation of the lesion. Placement of a matrix and a wedge. And here I'm selectively etching with phosphoric acid on the enamel only for the first 5 seconds, followed by an additional 5 seconds on the dentin, allowing for the full 10-second traditional etch on enamel in preparation for bonding the flowable material on the occlusal of the tooth, and the 5-second etch on the dentin in preparation for the glass ionomer. This shows the bulk fill of the resin-modified glass ionomer, followed by light curing for 20 seconds. So placement of a bonding agent here is debatable as to its necessity. Some suggest that since the glass ionomer has a resin component to it, that bonding is not needed. And this photo placement of the flowable material.